Hi, my name is Ben Ashworth. This is the Athletic Shoulder Podcast, and I'm delighted to welcome today Margie Olds onto the show. Welcome, Margie.
Thanks, Vin. It's great to talk to you.
Well, we're doing a bit of a home and away podcast, so we're looking forward to launching both of those. So it's kind of a switch of roles now. I'm the host, and you're
I'm
the
in the hot
guest.
seat.
You're in the hot seat now. I'll get my own back. I'll get my own back for that grilling on rate.
It's even nice to you. It's even nice.
Grilling on rate of force development I've just had. No, it was great. It's great fun. Um, and this time it's my turn to ask the question. So, look, firstly, I've introduced you already to the listeners, but can you just give a little bit of an introduction about kind of your journey and your background, a specific reference to kind of, you know, athletes and sport in terms of shoulders?
Yeah, okay. So I mean, my journey has been it started a similar time to yours as I was listening. I graduated from physio school 95 in New Zealand. Spent a couple of years here on a hospital rotation, and then I spent time in the US and then traveling a lot. As you know, probably Kiwis love to travel. I think we're such a long way away from anywhere. It's in our DNA, and at the time was doing quite a lot of kayaking, whitewater kayaking. So we're sort of working kayaking, and spent some time in South America paddling, and then ended up in London, as most Kiwis do, on their OE with my brother and sister and all my mates, staunching around London, and then stayed on and for a while, and then was fortunate enough to land a position at British Canoeing and as their lead physio in the run into the Athens Olympic Games. And so I guess I was interested in shoulder stuff beforehand, which I think made me a really good candidate to work in canoeing. And then working with canoeing athletes and the coaching staff and the team. I mean, what a phenomenal group of people. And was just a really, really great experience for me in terms of what happens in elite sport and the demands on the athletes. And then following Athens Olympics, really had to decide if I was coming back to New Zealand or was going to stay in the UK. And I came home, I guess, 2006 to see if I would like it here. And here I still am, and I think then moving from elite sport in the UK, where I was flying around the world with my athletes, to coming back into New Zealand certainly was a bit of a culture shock to start with. And then I really built on that, what I knew about shoulders, and sort of morphed into more of a research space. I started my master's in active stiffness. We had some experiences in canoeing looking at shoulders that dislocated and how to manage the unstable shoulder in that elite sport environment. And I became really aware what we didn't know at that stage, and that was 20 years ago, and so then started my master's work on tissue stiffness. I was convinced if we could make these people have their muscles come on fast enough and strong enough, I could stop them from dislocating, which is we talked into our podcast then on RFD. I think that's still such an important part of that picture, but as with all research, turns out to not be the world-shattering piece of information that you need, and so from there I have really moved into my PhD looking at trying to predict recurrent instability, because some of these people do so well and only have one event of instability, and some people go on to have recurrent episodes. And at the time there was lots of published papers around first-time surgery for those people, and I really felt that physio community and non-operative management needed to really step into this space to say, hey, hang on a minute, maybe for some people that's appropriate, but for some people we know that they're only going to have one event. And all the research still, it points us in the direction, well, look how good they are when we operate on all these people. And I'm like, well, yeah, because half of them didn't need your operation, so it's just really in that space. And I guess from my PhD is kind of then morphed into other research opportunities and really trying to drive change and educate clinicians about what we could do better to help, particularly the unstable shoulder. So I still work clinically now at the Auckland Shoulder Clinic here with a great team of physios, and work some part-time clinically and then part-time looking at research projects and things we could do better. And then recently started a podcast so I could talk to people like you, because I'm such a long way away from people, So it means then I can connect with people and really drill deeper into discussions around what I think is important for shoulder instability and how we can improve outcomes that is managed non-operatively. So I guess turns out that turned to be, when you find your thing, eh? So I've really, that's my thing. I just love it to the point that my husband is like, oh my God, she's doing her shoulder thing again, but I found my thing, and if everybody could find their thing, that would be fabulous.
Your husband sounds as supportive as my brother, who says you're not doing another boring thing about shoulders, are you? So
completely.
yeah,
He tells me up for playing with my numbers, because I'm in Excel going, oh, but if I did this and did that, then look, So yeah, it's
yeah,
fascinating. So
you've got it.
that's my story.
You've got it. Well, it's a great story. In fact, we realised that the first time we met was actually when I came. Well, I was at the British Olympic Association, and you came and did a talk around your work on stiffness, and you came
Yeah,
and did a workshop actually for the staff at the BOA on shoulders. And
that's right. Yeah,
yeah,
yeah.
at the time, as I said to you previously, the work was world leading around that idea of creating stiffness in shoulders and how that might actually affect
Mm,
the stability of the shoulder. Um,
mm,
Going back to the journey a little bit, the first thing you said there really resonates with me is this decision making around kind of, what we do, conservative or surgical. So can you
yeah.
kind of, I know it's a life's work, Margie, but can you try and unpick it for the listeners? What should they be doing when they get someone who comes onto their list, and ask the
So
question around
those
conservative and
those
surgical?
first specific. So my work in this PhD space is in specifically in that first time traumatic anterior shoulder dislocation. So the work that I speak of is really only relevant to those people. I think in the rate of recurrence changes the more you have. So really, but we know from the stuff that I've done, and this is in a New Zealand population too. So I think there are global differences, and we're trying, you and I both trying to draw on all this international research to what it means to the person in front of us. I think that might be different. The work that I did looked at taking a group of first-time dislocators, traumatic anterior people, and measuring a bunch of their risk factors. And we published the risk factors in a systematic review and BJSM in adults and children, and then looking at those risk factors to see if we could predict who was going to have recurrent instability. There were, we knew that age was going to be a factor. We thought sex was going to be a factor. We looked at a bunch of different things, and if people are interested in those risk factors, they should go to the BJSM articles, I guess. But what we found was that we could predict who was going to have recurrence, or more specifically, who was not going to have recurrence. There are a group of people who are seems not less likely to have recurrence, and if you're immobilized at first time, that decreases your risk. In a New Zealand population, sex isn't a factor, but I think lots of the female participants who were having dislocations were having them in high-risk sports. So I think there's some confounders in that space. We know age is a predictor, so being aged 16 to 25 increases your risk. The presence of a bony Bankart lesion increases your risk. We know high Spady scores. We measured both the WOSI, Western Ontario Stability Index, quality of your life specifically to shoulder instability, as well as the Spady score, the shoulder pain and disability index, and they're very similar. So we went with the Spady score because we thought it was more replicable, I guess, to people. but also kinesophobia was a risk factor. People who measured high levels of kinesophobia, measured with the TSK11, were at increased risk. And so I've put together this online calculator for people. They can go to my website, margieolds.com/PRIS, PRIS, and they can plug in those numbers and look to see if their athlete is at increased or decreased risk. What we don't know now is with the clinical applicability of this tool, and also clinicians need to remember that increased risk is not the same as surgery or not surgery. They're different outcomes. So we were looking at recurrence versus not recurrence. That is not the same as surgery versus not surgery. It just means you need to up your game with those people. That's what I think it means, So yes, fascinating, isn't it? I think some of the key findings when we published that work, people wanted to talk about immobilization. How long do we keep them immobilized for? And I wanted to talk about kinesophobia, and from there have really starting to drill deeper into this fear of re-injury and the psychosocial impact of that. And that has sort of taken me off on another branch, of trying to understand the impact of a shoulder dislocation and also how that can be associated with increased risk of having recurrence. It's incredibly important. How do I change that as a clinician, and how do I understand it more? So that's kind of where the stuff that I'm digging into at the minute.
Yeah, amidst RFD conversations as well.
Yes,
But
I couldn't let it go. A little
no,
sideline of how, well, maybe that's part of it. Do you know?
yeah,
Because we're trying to measure strength or a component. We're measuring, peak force, peak torque, how quickly you can get there. I still believe is a component. I think back to my research journey, how passionate I was about stiffness and how sure it was going to be the piece of the puzzle, Now maybe it's a little piece of the puzzle, and now I'm really drilling into some other components there. So.
yeah. I mean, I suppose I've got an opinion on that. I think you were barking up the right tree with stiffness. I think you were barking up the right tree. I just think we don't necessarily have the capability to measure it. And you and I, we've discussed this, but effectively, if we can find a tool to measure displacement and essentially reactivity and ability to stop the joint going beyond its constraints, that's got to be the right thing to be looking at. And I think you're barking up the right tree then. And actually,
I'll keep barking then, eh?
Keep barking. I'll help you when I finish my thesis. At the moment, I can't do
get
anything
that
else.
out of the way first.
Let's get that parked. But you've done yours. What's interesting about it is the other stuff you're going down is the confidence piece, like the psychosocial piece. But as you say, like, how can you be confident if you haven't got the physical capability to protect your joint? So I wonder,
how much they cross over. And I guess so this is what I'm mucking around with now clinically when I meet with my athlete. I'm not mucking around. I'm obviously making considered decisions with my patients, but how they are related. And there's definitely an element of that is how, if you've done something, then I feel more confident because I've been able to do that. I didn't realize I could do whatever test or whatever you made me do, and now I didn't, and now I can, and now I feel more confident. Or I was feeling not that great about playing, and then I played, and now I'm feeling that a bit more confident. We ended up in the course of this, developing some shoulder braces, and I'm also looking at putting on the shoulder braces. Now I feel safe. What is that? And trying to, and so I recently did that work with Guy Zillasol, looking at the glass shoulder, trying to really dig into what is the fear, or is it fear or re-injury anxiety? And that's a completely other discussion, but is it fear of pain or fear of missing out? And we found such a massive impact on the social identity, and all those factors are so important. The RFD is that one little component of that. It's been it's a really fascinating journey that we're still unpicking and still trying to understand.
You mentioned a couple of tools that you use to measure, like, kind of TSK tool, and
Yeah.
which if you're talking to our listeners and they wanted to use some tools to measure someone's confidence or to measure
Yeah.
someone's kind of feeling of I suppose like you know willingness or capability, like what would you use? What would you suggest
So
based on
I
your
think,
research?
yeah, at the time when I did the PhD, was looking at kinesophobia. I mean,
Yeah,
it's that Tampa scale of kinesophobia was developed for chronic low back pain, but it was the only thing that had been used in shoulders. And since then, we have the shoulder instability
yeah,
return to sport after injury scale, and I've done some work with Kate Webster digging into that a little more. We know that it has different constructs to the ACL RSI, where the ACL is just like a psychosocial readiness, but in shoulders, we see the fear of injury as a component. We see performance confidence as a component, as well as other emotions and the willingness to go through the rehab and the surgery again. So for clinicians, I think the shoulder instability return to sport after injury is a really good scale. There's some work out of Argentina that shows that it's predictive of or associated with return to play. We've looked at that in New Zealand. Wasn't associated in our population, and so, but also now you can do that with a 5-item
yeah.
questionnaire rather than the 12-item questionnaire, and we're just about to publish in that space as well. So there is a really short, quick version that you can use to monitor somebody's confidence slash fear of re-injury. So that's useful. But if you want to predict their recurrence, then you need to use the Tampa scale, because that's what we used in that other paper. But yeah, I think that's becoming more clinically applicable with only the 5 questions. And that's something that I now use in clinical practice to, as a measure, remeasure. Okay, so let's try this now. How's your confidence the following week? Or are we
Yep.
tracking online sort of?
Yeah, we use the short form of that, just largely
Yes,
as we said, like
yes.
the time poor nature of athletes means that if there's
Yes.
5 questions, it's better than 12 questions.
Yes, completely. My concern
um,
is around, I guess, I don't know, I'm interested to hear your thoughts on this, just to throw it back to you. So this is a shoulder instability return to sport measure, but we don't have anything for other types of shoulder injuries that measure the psychological readiness, shall we say? Like I know it's a massive factor in shoulder instability, and and I had a thought about that, which is why we included it in the PhD. Do you think we're sort of missing that in the other throwing type sports? Do you think that's as relevant, or what are your thoughts?
yeah, I mean, I kind of just, and you have dug into this way more than I have. Let me say this up front. But I just wanted a tool, and the people that I work in my team with, we wanted some tools to track someone's psychological
Yeah.
progression alongside and their confidence alongside the markers we love to look at.
Yes.
The kind of the forces and the rates and the other bits that we could talk about all day. But we wanted something quick,
Mm,
and so the Cersei 5 was the one that we went to, and then we also
yeah.
asked them simple like PFPS scores or whatever it is, which is
Yeah.
the 3 things that you're most limited in, and score them out of 10. And
Yeah.
then when we track that, we try and look at, well, our outcomes are not just about did their force improve, but did their confidence improve, for example. And we've started to build that information around a number of athletes, but
Mm,
it's not a publishable
mm,
study. It's just for our like
yeah.
interest around not only are we seeing change, but are they perceiving change as well? And that we use those 2 tools to track that.
Look, we know it's important, eh? We know it's important in terms of performance, but also now in terms of re-injury. And they've done lots of, I guess, as always in the shoulder, we're drawing out of what happens in the ACL, but,
Yep.
is so important in terms of being able to perform. So your brain, this is how I explain it to athletes, is that your brain isn't worried about your injury. You can actually focus on what it is that you need to do and achieve those outputs without that hanging in the back of your head. I think it takes up cortical space, for want of a better word, so trying to understand that better and understand what it means and how we can help these people. I've been doing some stuff using photo imagery, trying to make people, I can make people scared by looking at photos. It's phenomenal. And so then I measure, so I measure then their fear before and after. They save the photos on a phone, and so you get gradual exposure to that. So it's about graduated exposure to the fear-provoking device. And I've started looking at virtual reality to do that as well. How do I change people's fear? And part of it is the confidence, like you say, you do it, you feel a bit better about doing it, but we could do that in so many dimensions. So I've been playing around with that too. I put up images on my laptop of fear-provoking, and I've had patients run to the corner of the room feeling like they're nauseous, wanting to vomit. Get that off your screen, Margie. I'm like, which picture? Because it's, for me, I have never dislocated my shoulder, and I'm looking, oh, well, they look quite interesting, is your humeral head this way or that way? But their response is so visceral. It's so, it just, whether it's evoked memory, that's part of what we're learning around some of that functional MRI stuff. Is it the memory of doing it? Is it the feeling of apprehension? Is it about the emotion? Just trying to unpack some of that stuff so that I know how to modify it and change it, so that we talk about our similar passions are clearing people to return to sport, so that we can do that, first of all, safely, but then again to achieve their maximum performance so that they can live the life that they want, but I need to do that so it's safely. And we know that RFD, we both believe that's part of the picture. And now I'm understanding how the confidence and the fear of re-injury is also part of that picture, and how do I manipulate that as well to make sure my athlete is ready. So
and my simple brain goes to the sort of exposure, graded exposure, sensible progressions, making sure that the task that they're being asked to do matches their physical capability, and then that obviously is going to build confidence. And we've gone a long way from someone being out of pain and getting chucked back on the rugby field. We're very good about thinking about progressions. The teams I work with, the teams that you work with, we're pretty good at thinking that, but we're still getting people who break down in rehab processes. And I must say that one of the things that I'm really glad that we do is look at the confidence side as well. Because when there's a mismatch, because normally we see things track perfectly together. When there's a mismatch, it makes you look back at what you're doing again, and then you have to reflect on why are they not confident? They're super confident, or is it just because their personality is that they're not confident? There's a lot of stuff.
So many factors, isn't that? And that's their level of trace anxiety versus their re-injury anxiety, and who they were before their accident versus maybe there's some space in there as well.
Bottom line is what do we do with it, right? So what do we do with that once we find that we've got this lack of confidence? What do we do? What
I think is really important so first of all, as a clinician, you have to know your boundaries. I'm not a psychologist by any stretch of the imagination, but we also know that showing empathy and understanding to your patient, your athlete, makes a massive difference. And so now I routinely ask, well, how is that affecting you? How is your injury affecting you? How do you feel? And so that's either then a really short conversation because it's not such a factor, or that's a really big conversation because it's a massive factor. And I don't tend to, outside of my showing you images and making you frightened, we know that actually it changes their Tampa scale level. It changes their Cersei. So I do some of those kind of things, outside. So I think about then that imagery component. We're using the virtual reality because you have a person who comes in, those excessive, I can't lift my arm. Oh, well, here, pop yourself as an avatar in this virtual world. We record them and then we show them again
Yeah.
this is what you're doing. Oh my God, I didn't know I could do that. Do you know? And that's just builds their confidence in the same way. And again, it's just graded exposure. Like we
Yeah.
talk about graded exposure with all this strength work. And I don't know how much more I have to add to your conversation around, like the strengthening component. I published that paper, those clinical concepts paper with Tim all around how to really break down a motor control pattern versus a strength pattern and how to build that up, anterior versus posterior cuff. I'm a firm believer they operate differently. I think we need to address them differently, and especially in the unstable shoulder, looking at what happens to subscapularis, whether that's a eccentric, concentric control thing through range, or whether we're talking about, just strength. So prone lift off, down and dirty, just trying to get some endurance. I build endurance strength. We always see that they lose that inner range of strength. So you need to focus isometric in that inner range before you go through range, before you add speed, before you add perturbation. So I don't know. Is that what your question? I kind of moved up into my
You've taken us away from the we've done confidence now. I spoke to Joe Gibson about it as well. So I think
Listen.
I'm interested in digging into this though, like the Tim Hall stuff, because you talking about the kind of is it the apprehension test that you did, the supine apprehension stuff, or are you talking about
Yeah. So no, there was
anterior?
something
Yeah,
else we did. So
yeah.
so
My God,
just
when do you find
so
time for all this?
Tim. Yeah, so Tim has been a fabulous mentor for me. I spent some time in Kentucky learning fine wire EMG and kicking about with Tim and picking his brains, and he's such a experienced academic for somebody like me that has such great passion for and clinical ideas. The melding of that really came out in that paper, I think, looking at the strength in inner range, because if you don't have inner range cuff strength, you substitute with trunk rotation, scapular retraction. I'm talking specifically external rotators.
Yeah.
And similarly in your internal rotation strength, specifically trying to pull out subscapularis from your other big peak major lat dorsi that you commonly see. I typically haven't been measuring that now with my handheld dynamometer because I'm not sure how useful that is for me. So Tim really helped me pull those ideas out and really think in a structured way about trying to regain motor control, regain strength of your cuff without that substitution. So that then differentiating between humeral head movement and scapular movement, I think, is really important. We know, from some of Adele Fanning's work that these people, some of them are returning to sport, but the area that they lose their strength, that not mid range, but out here in outer range or of movement or inner range of muscle activity, we need to measure in that space because otherwise there's substitution. Yeah, and so talking to Tim, one of the projects we did while we were in Kentucky was looking at those return to sport tests. We called them the SART, shoulder arm return to sport tests. And so he really helped me then get the reliability of those, and along the way, and they're great in some factors. Some of them are really good tests, I think, but along the way we started looking into that dynamic stability that you talked of, and then remotely have worked with Alon Rabin in Israel. And so the timing for those meetings, me in New Zealand and him in Israel and Tim in Kentucky, meant that Alon had some really late nights, but then looking, and we found that people are apprehensive at that end range flexion, so eccentrically. Yeah. So using that as which is similar to your eye position, but in that place, looking at number of reps there, rather, and your ability to move back into that space rather than your peak force output. So many components, aren't there? That was more of an endurance. Can you move back into that space rather than a peak force? And I think all those components are important.
Yeah, I think so. I mean, just sort of, I know there's kind of a lot in here for the listeners, but if you do a PubMed search of Margie Olds, you'll find all of these papers. By the way, because I did prior to I knew you were well evidenced, but no, there's all these papers, but that one in particular, the supine moving apprehension test.
Yeah.
It's going in. It's basically, and people who like the work that I've done will love this as well, because it's long levers and it's starting to
Yes.
challenge the shoulder into different planes. And as you spoke about before, Tim was responsible for the original posterior shoulder endurance test. So it's just
Yes.
how do we challenge the shoulder in different planes? How do we put them in vulnerable positions and work out whether someone, feels
So
apprehensive or not?
firstly, well, you need to be, I mean, you are pretty vulnerable back there. So you need to make sure that people are safe back there
Yeah,
before people listen to this podcast and start dislocating
get going.
shoulders all over the world. It's good. You need to
Good
make
for
sure they're
business,
safe
Margie.
back there without a weight, and then graduate their weight so that they feel okay back there before you put them into this position. We also looked in that, your Y position, 135 abduction. But then surprisingly, it was that overhead position where people probably they just don't go far enough back because they don't feel confident. Probably, I think, without knowing that, is I can say this in a podcast because it's not a research paper, but do they have enough eccentric subscap control to really contain their humeral head and stop it from gliding forward? I think that's what happens there.
Yeah.
Yeah.
Yeah, and the contribution of the scapula as well. I think when you're talking
Yeah.
about, like, is it creating the right position for the shoulder to be able to access that overhead? Otherwise
Yeah.
it's changing the function of subscap.
Yeah.
That's interesting. When you're talking about the subscap stuff and you're saying, you've changed the way you look at that in terms of testing
Yeah.
subscap. Can you just go into that for me?
Well,
I'm
I
interested.
wonder, yeah, so this is just my clinical brain with some wonderings. I wonder, we talk about arthrogenic muscle inhibition in the knee, don't we? And really, I think because subscap is so hard to fine wire it's difficult to access. But I wonder, we know that recurrent instability affects subscapularis tendon. I wonder whether there is an element of switching off of the muscle. Definitely, if I look at here I am. People online can't even see me poking my fingers in my armpit, but I put the athlete supine and then I eccentrically load them, and you see they get to, maybe 45, 50 degrees of external rotation there, and you'll feel their subscap switch off, and you look at they lose control of their hand. So trying to eccentrically load and concentrically load that without using your pecs or your lats. And typically in the clinic, I just do that with finger palpation. But there's an EMG study in there too as well, looking to try and understand that further. And in my experience, so now I work as a specialist physio in New Zealand on seeing patients on referral who aren't doing well with physio. And typically people jump that step, that you look at your internal rotation. In New Zealand, that happens a lot with TheraBands, down here at 90, at 0, not always at 90. But what sometimes we're missing is that motor control and the reliance on your pecs and lats to drive that, still without any subscap. So still I wonder about that translation of their humeral head if you don't have that good subscap control. And so that's why I go looking for it now. I think that's a piece of the puzzle, and then
Yeah.
you can build that up, and then you can look into these fancy tests, but you've got to do the basics. And so it's a step by step basic approach to that before you go too fancy.
Yeah, that's great. I think that people miss from the subscap, the internal rotation stuff, because there's so much on throwing populations around the posterior
Yeah.
cuff that
Yeah, it's in there.
we
It's
we
in
don't
there.
we don't tend to look for internal rotation weakness.
No, we probably don't see it because we see pecs and lats. And so
Yeah,
what people should try next time they have a patient, if they can get there, maybe not acutely, but the patient lies prone and I just pop their hand in the middle of the back and they can't lift their hand off their back. I had a patient yesterday and she was like, why can't I do that? And she puts her other hand there going, oh my God, Margie, my physio has given me the impossible task. And her other hand lifts off her back fine, but she can't lift her affected hand off her back. And so then I just build endurance so that I can give them some baseline before we then start. I need something to build off first.
yep, yeah, that makes a lot of sense. And I think there's some stuff that we're looking at now, looking at kind of cross-sectional area muscle volume as well
Yeah.
around subscat, which
Yeah.
is another piece of this massive puzzle that we've created. But then we know if they've got the volume and the size, tendon's okay in terms of health, and they
Yes.
still can't do it. Well, something's not right around that retraining and motor control. Whereas if they
Yeah.
just don't have the size or the tendon health, then it's maybe more structural or related to that, and we need to think
Or
about building
both,
strength,
though,
or
eh?
both,
Because that's
combination
what
of both. Yeah,
we
yeah,
saw with VMO,
yeah,
like I say, we're just dragging along behind what happens in the knee. And so
yeah,
we see this muscle wasting that's probably driven from shoulder joint receptors.
yeah.
So that then shuts off. I think about it very simply, like you trying to make sense of it as you're losing your little motor homunculus man for subscap because he gets taken up with. So I'm
That's not
forever
how I think about
doing this in my motor homunculus on the side of my head. But I think you lose the little subscapulus motor homunculus space. It gets taken up by other things because I think of this inhibition. I don't know. We don't know that.
it. Yeah,
But
that's
yeah,
okay. We're on a
look,
podcast, not in a
yeah,
lab,
yeah,
so
exactly. I'm
we're
not
we're
defending my thesis.
we're all
So
right.
these are my
We're all right.
rambling thoughts.
I suppose there's so much you have obviously spent time thinking about, which is really clear. And I
Frightening.
think I just think you're curious like me.
Yeah,
You're in search of answers to help people other than
yeah,
yourself, and that means not just patients but clinicians as well. It's like how can we find better answers, and that's what makes it. That's what makes you, have a purpose, and that's
yeah.
fantastic. So I suppose, with all that going on, you know, like where do you think where do you think we're going? Like where do you think we're going as practitioners working in shoulders in sport?
I think, yeah, where are we going I mean, everybody's doing the best they can, eh? Do you know, like trying to help their their patients. I think we're starting to appreciate the complexity of it, aren't we?
Hmm.
For me specifically in the shoulder instability space, starting to appreciate the impact of these psychosocial factors and how important that is, but also starting to understand how we can build strength better. And for me, that means all the components of that. So starting then with endurance, building a good base, starting then for power, then looking at, rate of force and then perturbations. We're starting to understand how to scale that. We need to understand what that means, I guess. And as with anything, I think if we look back throughout our careers, I was thinking about this when after I would been emailing, and physios are magpies, aren't they? Like in New Zealand, we take some bright, they just go for the bright, shiny things and pick up the bright, shiny things without looking at necessarily all the picture. And so that's my concern as we really think and apply our clinical reasoning to all these different components and putting together then a battery or that are test sport and injury specific for return to sport. I think that's a space we're moving into, looking to see if we can develop something that's actually meaningful, that actually predicts injury or doesn't, and we've got all these wonderful tests now that in the last 10 years we didn't have, but still nothing on predictive validity. What do they mean? And we've got all these fancy numbers too, and we're following the numbers. But what do the numbers mean? We still don't know that. We don't have any published predictive validity around what's important, how much is important. Is that's the space I think we're in.
Yeah,
Lots of more questions, maybe.
that's it. I think you've nailed it. There's more questions. And I think from that side, if you're looking for being able to predict injuries, you're going to be disappointed. But we 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 can get closer to it, um, and by understanding the complexity as you outline, we can start to pick on the key factors that we believe are worth focusing on more. But you have to
Mm.
go through this. You have to go through this journey of looking at everything before you can come down and narrow it down to now
Yeah,
what
I think
matters.
I think so. And I think that's probably I mean, that probably varies by sport, doesn't it? Because for some people, speed isn't so much of a factor. You know, lots of the athletes that I train now, and speed is a really important factor, and I think it's important in developing that for reaction and that kind of thing. But I was working with a climber the other day, and actually having endurance strength in that overhead position, excluding her dynamic moves, of course, but like understanding that so that she has a confidence piece, she has an endurance muscle strength piece that we need to measure. But what we would measure for a climber is different than we would measure for a swimmer, is different than what we would measure for a rugby player, isn't it? So the complexity is you can do so many things with your arms. Whereas in the knee, you just sort of bounce backwards and forwards and twist a little, you know?
Yeah. I'm sure there are some excellent knee physios that would challenge that. Just because we
Of
picked a
course.
shoulder that's complex, Margie, we can't
Yeah,
start.
of course.
Yeah. Um, I'm actually, I'm actually of a slightly different mindset around it, I suppose, in that I still try to be as non-sport specific about testing.
Ah,
Yeah.
why?
Um, because I think as you go further towards the sport, you get less reliable in terms of what you're testing. So if I'm talking about formally testing something and putting a score on it, um, then I try and make sure we kind of make it as reliable as possible.
Yes.
Then we can look at stacking up sport against that. So, for example, to take it out of shoulders for a second, if you look at a simulated football exposure, so there'll be some cones and some change of direction and some
Yeah.
other things to create fatigue. We're looking at how that might change someone or how someone might respond to that in their recovery. Well, is it not better just to measure them before, get them to do their sport, or at whatever level we can quantify, and then remeasure something that we think is reliable? So, forced platform counter movement jumps pre and post running and change of direction session on the pitch. We know what their exposure was, and we know that we can rely on those tests to give us a pre and post.
Yeah,
That
but you're
and
missing so many
we
components. You
we call
miss
that.
the components there. That's where I think a part of the problem is, because if I have force in this direction, do I also then need to have force in that direction? Do I need peak force? Do I need rate of force? What are the different components? I think I'm not sure. I'm going to stay on my bandwagon. I'm going to keep barking up this tree, and you
Yeah,
I,
no,
I just think it's so important, and the demands are so different that in terms of it being meaningful, I hear what you're saying about taking reliable measures, definitely. But we know some of those, shoulder arm, those rotation tests, the line hops, we know that they're reliable, but we also we know that this dynamic position, we know that's got some reliability. So we need to be in my hands measuring in those different components, not measuring the same thing, measuring the same thing, because you're only seeing the things you're measuring. You're not seeing the things you're not. That's what I think.
yeah, yeah, and I think we're probably agreeing to agree, because
Oh, we don't
one.
have to, Ben. Where's the fun?
No, that's fine, but just for clarity, I think if you want to, we're talking about it as session cost. So
Right.
effectively, if I have a test like an ASH test, or I have a supine test of apprehension,
Yes.
we know the error within the test. We test them before. We might throw a plyo ball at them or get them to do loads of throws, or as we did live in Scandinavia, Martin Asker might get him to go through his throwing protocol, and then we'll remeasure the ER strength, and we'll measure an ASH test afterwards, and we'll see, has that changed. Now that doesn't mean that everything's
For
changed, but
what purpose? Help me understand for what purpose.
because we've got a test that we know reliably tests and probably overloads specific force characteristics, for example, like an ASH test. All right.
Yes, for some muscles.
Yeah, depending on, I mean, obviously, I've looked at the EMG, so
Yes.
it doesn't matter what test you pick, but you can then use that ideal of right, we're going to do session costs. You could do a cluster of tests, for example, which
Mm,
may stack up better. But
mm,
if we've got jumps, ACLs, you go on the pitch, you expose them to, ecologically, in terms of validity, they're doing what they do in their sport. The
yes,
ball's in there,
yes,
the space is the same. And then you come back in and you measure something that you know is reliable. We can't measure them on the pitch in terms of
no,
looking at forces. So the next best thing, I think, rather than to simulate a football-related fatiguing protocol,
mm.
is to actually do the sport. So that's, again, I
Yeah,
think
I disagree because I think you're missing components. I
we're not,
think
we
I hear
yeah,
what you're saying about the session costs, but maybe you don't see a change because you're not measuring the right thing.
yeah. I think when we start to go into those next bits is, we also are looking at we're not just focusing on a counter movement jump. We're not just focusing on earth test. There's all of the other components of the bits that we're looking at. But in terms of that specific, like, I suppose, mini experiment,
Yes.
that's going to give us more information than if we don't test them before, don't test them afterwards, send
Oh,
them out on the
completely.
pitch, right?
Completely.
But
Yeah, we agree. You like obviously if you don't measure anything, you don't know anything. You don't know if
yeah,
that's changed. My concern is that if we don't measure the right thing, then and it doesn't change, it doesn't mean there wasn't any change, means we weren't looking in the right place.
yeah, I think, again, along those lines in terms of the counter movement just stuff and ACLs and kind of, pretty well published bits around that is you can see a change, and we've seen it, in the moment of some of the key risk factors from an ACL perspective.
Yeah,
They will change in athletes where they have insufficient ability to produce forces fast enough in the time that they need to produce them at the time point that they need to produce them. And we can quantify all of that, but we can't quantify that when we watch them move, and we can't
yeah,
quantify that when we watch them throw and catch a ball
yeah,
in the same way. So we have to, I think, try and unpick the complexity a little bit and break it down into things that ultimately we can measure. And that's the way that I tend to look at it,
yeah.
alongside being happy that that's the science, but we've also got the art. So
Yes,
we've
the
got
balance
license.
of it.
Yeah, we've exactly that. That's why I say we agree to agree or disagree to a disagree,
It's okay.
is because I think people need to know that beyond the fact that Ben's an Ash test person and Margie's a SARTs person, and we all look at all these different things, and
Yeah, it's bigger than that,
we
isn't
try
it?
and build the story,
Yeah.
not just looking at the picture. Yeah,
Yeah, I think what's I mean, but just apart from my flippant comment around knees, obviously, the demands of shoulders are so different that I actually think we need really good, reliable tests in lots of different places for different people that the clinicians can put together a cluster of tests that makes sense,
yeah,
so that makes sense for that and isn't necessarily just the one test looking at session costs. That's what I think. But I don't know. I mean, we don't know, do we? And I guess we're back to what's really important. That's the space we're in now. Like you and I don't necessarily need to agree, but at some point in the future, we will know what's important in terms of predicting performance, return to performance, and re-injury as well. That's where I think the space is still,
yeah,
and we can have our ideas and agree and disagree, but I think we need to keep looking into that space, looking into predictive validity to see actually what is important.
yeah. I'll still tell you that's going to be difficult too. Like the sitting there looking at the numbers that you need in terms of the context of predictive stuff.
Yeah, yeah,
You know,
completely. I'm not saying it's easy. I'm not saying it's easy, and that's probably why it hasn't been done. But in terms of perhaps like throwing speed, like I had I have a volleyball patient at the minute who is unstable right back in that outer range, and the physio had done the ASH test. Oh, look, the numbers are the same. I'm like, well, yeah, they are, but what's his numbers like right back here in outer range external rotation where he's taking that impact?
Mm.
that's what I think's important. So, but again, I don't know. That's just me with my clinician hat on.
Yeah, you'd have to pass. You'd have to pass the AF test, but that's only, one
One
level.
component.
Because if you're a throwing athlete, you also have to pass the ability to get back into this position and be able to produce internal rotation force. So there's
Yeah.
again, it's perfect because it's not a one test fits all. It's not about
Yes.
biasing. It's about making sure you understand the requirements of the sport from a needs analysis perspective, and you try and align testing
Yes.
to match up some of those areas that we want to target to see, can we find weaknesses that we can potentially train, I suppose,
Yeah,
is
you
the,
can change, and then
yeah.
you, like you say, you measure, you address that with your exercises or your programming or however you do, and then re-measure. But
Yeah.
yeah, we can agree. So
Don't worry, I don't mind a disagreement. I'm not sure I don't. I sat in Premier League football morning meetings for 6 years. Yeah,
yes,
don't trust me. I mean, it's not for this podcast, but we've had a few disagreements, which are healthy. They're
yeah,
a comfortably challenging environment. Will move things forward. But I think that's to have that sort of discussion on air shows people, number one, that it isn't simple, you know,
yes,
and number two, there's a lot of thought and a lot of conversations behind the scenes that have gone into where we are already at, and we still don't
yes,
know what we don't know.
yes, and that's, I guess, and that's the place where we're at right now, isn't it? And then how do we, that I think by the disagreement, then I'll take away from then that's how we learn and move forward.
Yep,
Um,
yep,
so
for
yeah, I think
sure.
it's healthy.
So apart from that, like I know you're sort of a busy person. So what's next for you? Where are things next for you, Margie? What are you doing
Yeah,
apart from
so
trying to solve predictive
yes,
predictive testing?
solve the problems of predicting re-injury in my shoulder athletes. Oh my goodness, there's so much work to do in that space, eh? So, look, I still we're based here in New Zealand, and I'm working clinically still with patients as a specialist shoulder physio, and I see that happening, for some time. And then still working with researchers uh, domestically and internationally, looking at trying to improve outcomes, particularly for people with shoulder instability. Like I said, that's the thing that spins my wheels. I almost can't help myself. So, and so looking to really improve, clinical testing, clinical management of this population, trying to really take a stand, I guess, against primary surgery in this space, and making sure that we are doing the best we can for these patients non-operatively. So, yeah, that's the thing that's continuing to drive me for at least a few more years yet. So,
Fantastic. And where can people find you and your sort of courses? And you mentioned your brace and stuff. Where can people find you?
yeah, so I have a website, margieolds.com, and that's where you can find that calculator for predicting tools. And then there's links then to some online courses that I have, and a link through to the Flawless Motion website that has our shoulder brace. I recently started the Gleno Humoral Gurus podcast, which has been great to do this,
Yeah.
home and away, you call it, like, but just spend some time with you today, really trying to, because I want to understand people's thoughts and how that could challenge my own thinking. So there's some really nice discussions. I'm really enjoying that as well. So that's just started a few months ago, and I imagine that will, continue as well. So yeah, people can find me, particularly probably if they go to the website's a good place to start, or like you say, on any of those social media type things. And I'm not super active, but I try to contribute where I can.
Well, you're more than contributing. We'll link up to your research and some of the stuff that we've mentioned you covered. I mean, it's going to be difficult. The long list. It's going to be difficult to cover it in the show notes. But I think for everybody who's been listening, they can hear your passion and also can hear the vast experience that you bring to the table. So thanks again for the conversation and coming and joining us today.
Yeah,
Fantastic.
it's been wonderful chatting with you. Thank you.